Hello, AGNP students. Welcome to week 3. So this week we'll be focusing on HENT and that covers chapters 11 through 14. We'll just review the anatomy, which you already covered in your undergraduate nursing programs, especially focusing on the head, neck, eyes, ears, nose, and throat. And I also encourage you to familiarize yourself with the learning objectives for this week. So we start by reviewing the head and neck, or the surface anatomy, which are very important, especially to understand the terminology like the frontal. That's very important, especially when you are doing your documentation or your charting. For example, if you want to talk about the location of the lesions, pain, or trauma. Also identifying specific locations like the submandibular salivary glands. That's very critical because that may show like some swelling in the areas that can quickly alert you about some conditions like mumps, uh, which may affect the chicks and or maybe even other viral infections that you may be able to visualize in the facial region. So when you take a look at the neck, this serves as a very critical vesicular and respiratory structure. For example, the sternocleidomastoid muscle is your primary topographical landmark. You can see that on the picture. And you can also look at how it divides the neck into an anterior and posterior. It divides the neck into two different parts, the anterior and then the posterior are cervical triangles. And so the thyroid gland is also situated over the trachea, just below the cricoid cartilage. This is also highly vesicular. Any thyroid enlargement like goiter must be carefully palpated and auscultated. I mentioned something about the lymph nodes that these are the network as you can see on that image of those lymph nodes. It's very important to remember them. You don't have to memorize all of them, but in your assessment, you can point out on the most important ones. The parotid is the preauricular. Just you can point to some of them and cover as many as you can. This is very important, for example, to help point out some issues like lymphatic drainage, which usually flows downward. And well, for example, dental abscess, throat infection, those are things to remember, which can be indicated by the how the submandibular node is affected. All right, so if you notice any hard or fixated, not fixed node in any of those lymph nodes, that may be a red flag for malignancy. So when you are conducting your physical assessment or physical exam, we all know what you have to do first is just your inspection, which precedes any palpation or even auscultation. So, for example, part of the hair is to inspect the scalp very thoroughly, noting any melanomas, which can hide and may not be noticed by the patient. And so, in the health history, also, headache is a very common complaint that patients present with. And it also requires a high index of suspicion. You must rule out some of those red flags. For example, a sudden thunderclap onset or association with fever and stiff neck, which may indicate medical emergencies. And some of you are already thinking about, is it hemorrhage or is it meningitis? Those are two possible differential diagnoses. So then when you are recording your examination, and accurate and then systematic documentation is very, very important, using standard terminology that we talked about a few minutes ago. And then under the health promotion, you may wonder why we are focusing on this like every week. Yeah, this is very important because, for example, let's say you are screening for thyroid dysfunction or thyroid disease in women over 50 years old. So, taking a comprehensive thyroid history involves assessing the systemic symptoms like metabolic changes or structural thyroid issues frequently present as functional. But most patients may have those thyroid concerns or issues, but may ignore them. So, whole body systems is very important to understand some of those conditions like thyroid cancer or goiter. Transitioning to chapter 12, and this is the most intricate sensory organ. And we begin with the external anatomy, which we'll review. And for example, the eyelids, the eyelashes, which provide mechanical protection. And while the conjunctiva, for example, is a clear mucous membrane that lubricates the eye. We already know about the anatomy and physiology, but this is just a quick review to help you pinpoint those conditions and what locations or what areas they affect. Understanding the anatomy of the interior chamber is also critical. So, to understand the drainage pathways, for example, uh, in case there's any obstruction. So, for example, for the older adults, you also have to understand the intraocular pressure, which may lead to glaucoma. That's very important, and it may cause irreversible blindness if it's not caught uh, promptly. But as we age, these are conditions which most of the times happen. For example, if you we can review the macula, which dictates the patient's central vision, while, like for example, the optic disc acts as a window into the cranial vault, where swelling may indicate increased IOP or intracranial pressure. So the coordinated movement of our eye is controlled by six extraocular muscles, which are innervated by cranial nerves. And you already know about those cranial nerves, three, four, and six. They all work together to control the or to coordinate the movement of eyes. So this table here is just a quick reminder of how they are activated and how to assess them in a specific direction. So you can use the H test. That's what we use to make sure we cover all the directions, H as a letter H. And this is very important to help ensure the smooth pursuit in all six cardinal directions of gaze, looking carefully at any lag or nystagmus. Next is the eye history and examination, which is very essential as part of the triage process. Let's say, for example, a patient comes to you and they are reporting painless loss of vision or experiencing sensation like a dark curtain descending over their visual field. This is describing retinal detachment. So this requires an immediate consult with the ophthalmologist, for example. In the same situation, a new onset of floaters accompanied by flashing lights. These are the most common complaints you will hear about the patients in primary care. So that's another major red flag. So when beginning your physical exam or physical assessment, visual acuity is your most vital metric and must always be tested before shining the black lights. Proper assessment of the pupils is also very important, which requires noting both direct and conceptual reactions to light. Testing visual acuity, you're already aware of that. You can use Cinelin chart, for patients or for adults who are able to read. And then you can also use tumbling E or Allen charts for young or pediatric patients, or we cover patients who are 13 years and older, or patients who are unable to read. Though you can also use the tumbling E or the Allen chart. So the swinging flashlight test is another special technique which you can use to detect any afferent defect in the pupils. So then we can move to chapter 13, which focuses on the ears and the nose. So this is very important to understand the division of the ear, for example, in the three chambers, which you already know in the anatomy and physiology. But this is very important to assess any abnormalities or any pathologies that you may notice in your patients. So I encourage you to review this to understand them. It may seem like a repetition, but it's gonna be very handy. So let's move on to the nose. The internal nasal cavity is very specialized for environmental conditioning system. The turbinates but increase the internal surface area, allowing the mucosal vesicular bed to rapidly warm and humidify the air. Those are some of the anatomy and physiology or pathophysiology concepts that we need to remember as we assess our patients. So then when you are checking your health history, this will be our focus. Uh, for the health history for the year, we have to separate through vertigo from general dizziness or lightheadedness that some patients present with. A true vertigo indicates vestibular or inner ear pathology. That's the condition that affects the inner ear. For hearing loss, for example, sudden sensory neural loss requires an urgent specialist referral. For example, involve the audiologists. For the nose, frequently ask patients about their use of topical decongestant sprays like Afrin. overuse beyond 3 consecutive days, for example, is something I expect that you covered or you're covering in pharmacology. It may lead to severe or rebound congestion, which we call rhinitis medicamentosa. So for the physical exam of the year, it usually begins with inspection and then palpation. If pulling the olicle, the tragus causes severe pain, so that may suggest acute otitis externa, which is only or also commonly known as the swimmer's ear if you are pulling the olicle. The otoscopic exam requires deliberate, safe technique. You must visualize and verify the color and contour of the tympanic membrane when inspecting the external ear. So you have to be more careful for basal cell carcinomas, which you may also notice on the ear, and as those may look like superior edge of the pinner, which should, especially for patients with a history of sun exposure. There are some tests which you might be familiar with. One of them is the whisper test, which is excellent validated screening tool for auditory acuity. It's very simple because you whisper to ensure your voice is standardized and truly heard by the patient, not just spoken quietly. If a patient fails this initial whisper screen, and then that's another different story. But we can use the Weber and the Lin tuning fork tests, which are also other alternative tests that we can do. Why do we do these tests? Here are some of the guidelines showing you how you can whisper uh, standing 2 feet behind the patient who is seated, and then make sure they are unable to lead to radio lips. So all we can also do other tests like Weber test or Lane test. The most important thing is to assess the hearing loss. So hearing loss may be sensory neural, or it can be um, when you are comparing both the air conduction to bone conduction. Are they hearing that sound at the same time? Or is it higher, for example, at the bone conduction as it is for the air conduction? So in that case, you may rule out some hearing loss because they are not receiving the sound at the same time or the same way. So in this case, you may refer them to the audiologist, or you may also recommend some occupational or recreational noise exposure prevention. So it's very important to differentiate what you're assessing for. For example, the Weband, the rain tuning fork are very essential when you are differentiating conductive from sensory neural hearing loss. And this is done before any audiometry is ordered through the audiologist. So in your assessment of the nose, we look at the mucosa to distinguish any allergic from infectious etiologies. Viral infections, for example, will make the mucosa look red and swollen, but chronic allergies usually present with pale and bluish or baggy turbinates. This is very important to look at to inspect the color and how it presents to distinguish between any viral or chronic viral infections and chronic allergies. So make sure you palpate the sinuses and then ask patients if they have any pain or if they have any facial pressure. That's very important too. Any tenderness over the frontal sinuses may also indicate that they have acute sinusitis. So this is another anatomy and physiology of the mouth and teeth, which you can quickly review as we evaluate both. We assess digestive and respiratory systems. These are very important. And this is a continuity of anatomy and physiology. For example, the pharynx, it's a very common passageway or pathway for the food and air. And what cranial nerve applies here? It's cranial nerve 9 when we ask patient to say ah, and that's cranial nerve 9 that we're assessing, the vagus nerve. And we can also visualize the tonsils. That's something very important to notice. And we can also grade them based on their size in relation to their path to the airway. So if they are too enlarged, that may cause, you may guess what condition, sleep apnea, and because they may compromise the airway. So that's very important when we ask patient to say R, and then look at the size of the tonsils. So also health history and physical exams are very important. For example, we may be able to assess some conditions like pharyngitis, which is very common in primary care. And patient may present with what symptoms like hoarseness, which lasts for more than 2 to 3 weeks, especially patients who have a history of smoking. And we may also refer them to other specialists because they might present with laryngeal cancer. That's very possible. So the physical exam requires also excellent lighting. Lighting is very important, and then you can also use the tongue blades to inspect the sides and under surface of the tongue, as there might be high risk zones like squamous cell carcinoma that we might not see. So if we notice those, we may refer those patients to the oncologist. Same for those patients who might have laryngeal cancer. Some abnormalities may be noted as you do your health history and then perform the physical exam. For example, the oral cavity can reveal a lot about the patient's systemic health. For example, thrush may be observed, which appears as white patches that can be scraped off. It's often also seen in immunocompromised patients. And leukoplakia, also a white patch that cannot be scraped off. So you see the difference between thrush or candidiasis and then leukoplakia. Also, those are both white patches, but leukoplakia cannot be scraped off, but the oral thrush can be scraped off. And leukoplakia can also be precancerous. So look at some other warning signs, other red flags like complex spots, which is another sign of measles. Always advise the patients to also assess their risk factors, look at their risk factors at home. For example, one of the risk factors for those cancers is alcohol use, heavy smoking, heavy cigarette smoking, or using of tobacco, which may also increase the risks of other malignancies affecting the mouth. So this is the end of today's presentation. This was one of the longest uh, presentation because it has so many chapters. But let me know if you have any questions or any concerns or feedback. Thank you.